Starting with the pharmacology of cardiac failure, aka heart failure, what exactly do we mean by the term heart failure? A heart failure is a condition of the heart in which the heart is unable to either accumulate the blood or to eject the blood that it accumulates from the rest of the body. And there can be a lot of functional and anatomical defects that can lead to the development of cardiac failure. For example, cardiac failure is often a sequelae of myocardial infarction. In MI, there is ischemia followed by necrosis of the heart muscle, and therefore the contractile ability of the heart is reduced. At least a portion of the cardiac muscle is affected, and sometimes there is gross, generalized damage to the heart muscle, which makes the heart unable to pump the blood which it receives. So this is basically an example of systolic heart failure. But there can be a lot of different causes which can lead to heart failure. For example, there might be a congenital heart defect like a ventricular septal defect, which might impair the ability of the heart to pump blood. And when the ability of the heart to pump blood is impaired, it basically eventually culminates in further damages incurred by the heart muscle, and so the heart's ability to pump blood becomes progressively less because of that initial defect. Because obviously the heart is supplying the oxygen to the rest of the body and also to itself via the coronary arteries, and this is a very complicated thing. So I'll try to simplify all of this as much as I can. So when you talk about the heart, there are certain concepts which you need to keep in mind. For example, preload is the amount of stretch on the heart muscle, and obviously the amount of stretch on the cardiac muscle is dependent on the amount of blood that basically reaches the heart from the rest of the body. And the greater the volume that reaches the heart, the greater will be the preload, the greater will be the stretch on the heart muscle, and the greater will be the force developed by the heart secondary to that stretch. These are concepts which we've already talked about in physiology. Obviously, when there's something very stretchable and you put some volume of liquid in it, the tension in the walls of that stretchable object increase in proportion to the volume that it is containing. So this is preload, right? And so when a person comes to you with heart failure, right, one thing you can do is attempt to reduce the volume of the amount of preload. And the drug of choice when it comes to reducing preload are basically diuretics. And there are various types of diuretics which we've already done in second year physiology. Alright. For example, we have something called Furosemide, which is basically a loop diuretic. So that is the drug of choice when it comes to heart failure. Bumatinide is also used because when there is diuresis, there is more water lost from the body along with salt via the kidney. So there is less volume in the body and less volume will go to the heart, and there will be less stretch on the heart muscle, and therefore the heart will have to produce less force and therefore will have to do less work, and it is able to preserve its remaining function. So as far as preload is concerned, one way we can reduce that is via administering diuretics. Now, second important thing is the fact when there is heart failure, the heart is unable to do its job, and the body kind of attempts to compensate for that in a number of ways. There are two forms of compensation: neurohumoral compensation and the compensation via the kidney. The neurohumoral compensation, if you remember from second year physiology, is a much more acute compensation, and it involves the activation of the sympathetic nervous system with its centers located in the CNS. So basically the sympathetic drive is increased and the rate of the heart increases, and the contractility developed by the myocytes also increases, but this is not good because you're increasing the amount of work the heart has to do, and the heart is unable to do the work that it already has. So this basically leads to further damage to the myocytes. Similarly, the kidney, when it basically recognizes a fall in BP, because when the heart is unable to pump the blood that it needs to pump, the stroke volume obviously falls, and stroke volume has a direct relation to BP. So whenever the stroke volume falls, there will be a concurrent fall in the BP, and when the BP falls, that can be detected by a number of receptors in the body. Again, back to first year physiology. The kidney, for example, is able to detect the fall in BP, because when the BP falls, so does the GFR, and the kidney is able to recognize the fall in GFR, and so it basically attempts to compensate by increasing the retention or increasing the reabsorption of the water and the salts. But this is a good thing, because we have more preload, there will be more blood pumped out, and to some extent the BP will rise initially as a result of this compensation. But because the heart is not able to cope with the amount of work it has when there is volume retention as a compensatory mechanism, that leads to further damage to the heart muscle. So this is why diuretics are very important, because they are preventing this very bad or very well intentioned compensatory response by the body, which actually ends up doing more harm than good. So this is important. So afterload is the amount of force that the heart works against in order to pump blood. And obviously, what are the factors that determine the afterload? Number one being the peripheral resistance. The more peripheral resistance, the more pressure the heart has to build in order to pump the blood in spite of the resistance or the impedance that is offered by the blood vessels. Right? So afterload is also something that makes the heart pump harder than it should, or it needs to, for that matter. So one way we can sort of like help the heart out is by reducing the afterload, right? And how can we reduce the afterload? By reducing the constriction of the blood vessels, therefore reducing the resistance. Again, back to first year physiology and back to our concepts of physics. Whenever we talk about resistance offered through a vessel, we consider in terms of the length and in terms of the diameter. And there is a very interesting relation between the diameter and the resistance. It is an inverse relationship proportional to 1 by r to the power 4, r being the radius. So when we dilate the vessels, we are reducing the resistance offered. So we can go with vasodilators. One other important thing as far as preload is concerned is that if we use venodilators, we also end up reducing the preload. Again, back to first year physiology, the majority of the blood is actually found in the venous system as opposed to the arterial system, and when we increase the diameter of the venous system, we are increasing the capacity, and the blood remains the same, but now we have a wider surface area, and so the blood basically exerts less pressure on the vessel wall, and so the tone developed is sort of reduced, and this leads to a fall in the venous return. And there are a couple of formulas which we did in first year physiology, but you just need to have a bit of an idea of what that was all about. So CVS physiology was a very important thing. Afterload, vasodilators, not just the arterioles but the veins as well, right? So when you reduce the vasoconstriction, the normal amount of vasoconstriction, you're reducing the afterload. The heart has to work less. So you can go with an arteriodilator and you can go with a venodilator, right? And this is important because oftentimes a combination drug is given in patients with heart failure who don't respond well to certain other first-line therapies. And this combination is basically a combination of hydralazine. Now, if you've already done the drugs used in hypertension, the AB series of hypertension, we use ACE inhibitors, we sometimes use beta blockers, we use calcium channel blockers, and we use diuretics. My apologies. Hydralazine is basically a prodrug of nitric oxide, and it is a very important drug as far as the treatment of angina pectoris is concerned. It is an anti-anginal drug. It is a prodrug of nitric oxide. It is also a direct vasodilator which you can use in the treatment of hypertension. And it is specific to arterioles. It is an arteriodilator. It does not have any effect on the venous system. So if you were to say give hydralazine, actually you do give hydralazine, it isn't a supposition, you give hydralazine in combination with isosorbide dinitrite. Now isosorbide dinitrite is basically another drug which you will consider when you will talk about anti-anginal drugs. We use the nitrates as anti-anginal drugs because they basically lead to vasodilation of the coronaries, and when the coronaries are vasodilated, there is more blood going to the heart, and so there is a better match between oxygen demand and oxygen requirement. Secondarily, the nitrates lead to vasodilation, right? And so the afterload is also reduced, so the amount of work the heart needs to do is also reduced, and it's getting more oxygen, so there's a better match between the work done and the energy needed for the work to be done. So this is a combination which is very often given in patients of cardiac failure, systolic cardiac failure to be exact. Let me just underline this because this is a very important combination. Right, so now let's talk about drugs which we can give in order to sort of like inhibit a system known as the Ras system, which is renin-angiotensin aldosterone system, which detects a fall in BP, right? So the Ras system is actually located in the kidney, again something we've done in second year physiology. And so what happens is that we have renin formation by the kidney in response to sympathetic stimulation, in response to a fall in BP. This renin leads to the conversion of angiotensin 1 followed by angiotensin 2. Angiotensin 2 leads to the formation of aldosterone, and aldosterone basically leads to the retention of water and salt in the body, and the angiotensin 2 itself is a vasoconstrictor. And we don't want vasoconstriction in heart failure because vasoconstriction leads to increased afterload, which means the heart has to do more work to pump the blood which it receives. Vasoconstriction is bad, and the retention of water and fluid, fluid and salt is also bad because that leads to increased preload. So when we give Ras inhibitors, we're decreasing both the preload and the afterload. And why are these two increasing? Because of a neurohormonal response by the body in an attempt to compensate the fall in BP as detected by the sympathetic nervous system via the baroreceptor system, etc. Alright, so we go with Ras inhibitors too, very important. We can say that the Ras inhibitors are that category of drugs which sort of go against the neurohormonal response. And the important thing to recognize is that they cause a fall in both the preload as well as the afterload. Fall in both the preload and the afterload. So this is a very important thing which you really do need to understand. How so? Because of the inhibition of the vasoconstriction carried out by the angiotensin 2, as well as an inhibition of the water retention and the salt retention, which is a primary mode of action of aldosterone, which is produced as a result or a consequence of the stimulation of the Ras system in the kidney. So this is very important. The Ras system has other effects. For one thing, the aldosterone produced as a consequence of the renin-angiotensin aldosterone system activation leads to hypertrophy of the heart. Now, hypertrophy of the heart is a bad thing. There is no situation in which you will observe physiological hypertrophy of the heart, right? Like when we talk about the skeletal muscle system, there are both physiological as well as pathological conditions in which the heart can undergo hypertrophy, right? But when it comes to the heart, there is only the pathological option, and there are a couple of things which can lead to such a change. Now this is bad Whenever there's this change, the heart becomes hypertrophied. That leads to remodeling of the heart, fibrosis of the heart, and the fibrotic heart does not do its job. Okay, so bad. This is something very bad which we are preventing by preventing the stimulation of the RAS system, and we'll talk about how that works later. Secondarily, the effect of norepinephrine, which is a part of the sympathetic nervous system, needs to be considered too. Right. So what are the effects? There's a fall in the preload, there is a fall in the afterload, very important. There is prevention of cardiac remodeling. And why is cardiac remodeling bad? We also refer to it as ventricular remodeling, because this is actually fibrosis of the heart, and the fibrotic heart is not able to do its job, so it worsens the cardiac failure. Let's talk about the Ras inhibitors. We can use various things. Okay, one thing I want to kind of like give a bit of emphasis on is that these drugs can be used in a lot of different situations. For example, diuretics are also used in the treatment of hypertension. Right? We use the vasodilators in the treatment of hypertension, although they're not exactly first line. They're mostly used in moderate to severe hypertension, and they're used together with the beta blockers or the diuretics in order to offset certain side effects of these drugs which are bad if they're allowed to happen. And we also give Ras inhibitors in a couple of things. We use it in addition to heart failure, we use it again in hypertension, and over there they have a lot of effect because you're stopping the aldosterone system from building up fluid, which is bad in hypertension, and you're also stopping the vasoconstriction, which is again bad in hypertension. Alright, back to Ras inhibitors and the prevention of cardiac remodeling. So how can you inhibit the Ras system? Some of the things are pretty easy. If you've already gone over the antihypertensive drugs, you can go with something like an ACE inhibitor so that the angiotensin 1 is not converted to angiotensin 2. You can go with an angiotensin 2 receptor blocker. You can go with something that prevents the formation of angiotensin 1, right? Or you can basically inhibit the sympathetic stimulus which leads to the activation of the RAS system. So this is an interesting thing because we do know that the kidney responds to the fall in BP, but from where does it get the signals? Part of the signals are received from the sympathetic nervous system. So if we sort of like block that influence, we end up stopping or we end up inhibiting the whole process. So one of the drugs that we use to prevent the activation of the RAS system in the treatment of cardiac heart failure are the use of beta blockers. Where else do we use beta blockers? In a couple of places. We do occasionally use them as antihypertensive drugs. We also use them, interestingly, in the treatment of angina, because in angina the heart is unable to cope with the amount of work that it has. So if you reduce the heart rate, you kind of end up solving that problem. So one thing that you can use are the beta blockers. Right. So first of all, you can go with the beta blocker, right? And that will end up inhibiting the whole system. What else does a beta blocker do when you prescribe it to a patient of cardiac heart failure? What other effects? First of all, obviously there is the inhibition of renin release. And when the release of renin is prevented, the RAS system is inhibited. This is something we've talked about in detail. What else does a beta blocker do in a case of cardiac heart failure? Because we are stopping we are nipping the formation of aldosterone in the bud, we are preventing the remodeling of the heart, prevention of remodeling of the heart. And so we can, if they ask you to name a couple of drugs which increase lifespan or increase survival in patients of cardiac heart failure, you name those drugs which prevent remodeling, including the beta blockers. Prevention of remodeling of the heart, I'm pretty sure these are, prevention of remodeling of the heart. This is the second effect. The third effect is, as you can expect, Beta blockers target beta receptors in the body. Which receptors are found in the heart? Beta 1 receptors. When those are inhibited, what effect do you see? You see a fall in heart rate. Why is that bad? Because when the heart rate is less, the heart has to do less work. It is able to preserve its energies. Fall in the heart rate. So this is one of the more acute effects of beta blockers, which you see as soon as you administer the drug. It causes bradycardia. Right. Too much sympathetic influence on the heart also contributes to the development of remodeling. Something to keep in mind. When there is a fall in the heart rate, there is a subsequent fall in the cardiac output, which means there is less workload on the heart. And when the heart rate is less, the diastolic interval is increased. And there are two intervals of the heart, or stages, diastole and systole. In diastole, the heart is getting perfused, but not in systole, because in systole the heart muscle contracts, and so the lumen of the coronary arteries is obliterated because of that pressure. So the heart is not perfused by the coronary arteries during systole, but it is perfused during diastole. So when you reduce heart rate, the proportionate or the relative interval of diastole increases, so the perfusion to the heart improves, and which helps in the survival of the cardiac muscle. So you can say increased perfusion time secondary to the fall in the heart rate. Right, so this is another important effect which we've already considered. Now, interestingly, beta blockers also cause a vasodilation, which is good because it reduces the afterload. Interesting, right? So the afterload is getting reduced because of the effect on the Ras system, and also because of the fact that renin is not getting produced, because renin is itself a vasoconstrictor. So we can go with vasodilation, and in brackets we can mention that it is because of the renin not getting produced, basically. So we are done with the beta blockers, and we've talked about the Ras inhibitors. Obviously, when we don't have any angiotensin 2, there isn't any vasoconstriction. There's a fall in the afterload, and there is a fall in the preload because there is less water retention and less fluid retention by the kidney, and there is less remodeling because there is less aldosterone getting produced. So these are the effects of the ACE inhibitors and the ARBs, which are aldosterone receptor blockers. Right. So ACE inhibitors and the ARBs are very good in the treatment of congestive heart failure, and they're also excellent in the treatment of hypertension. So if a patient comes with these two concurrent disorders, a person who has hypertension and is developing congestive heart failure, possibly because of the hypertension and probably also because of certain other coexisting comorbids. So the drug of choice that you would prescribe to such a patient would be the ACE inhibitors or the ARBs, because they're targeting both comorbidities in a very excellent manner. In congestive heart failure, you tend to prefer the ACE inhibitors over the ARBs because bradykinin, which is basically something that is stopped from degradation because of the ACE inhibitors, is a vasodilator. So it sort of like compounds the direct effect of the ACE inhibitors. Right. Another interesting thing is that when you're going for the treatment of congestive heart failure and you want to give an ARB, as I mentioned, is an angiotensin receptor blocker. So when angiotensin 2 is produced and it wants to have an effect on the adrenal cortex so that aldosterone gets produced, or maybe it wants to have a direct effect on the vasculature to lead to vasoconstriction. In order for it to be able to do that, it needs to go to the site of action and bind to its receptors present on that site. But if you were to give an angiotensin 2 receptor blocker, there would be competitive inhibition, there would be something else occupying those sites, and so the angiotensin won't have any effect at all. That is an ARB, which is very good in hypertension treatment as well as in the treatment of CHF. Right? So when you give an angiotensin receptor blocker, you give it in combination with a drug known as neprilysin inhibitor. What do you give it with? You give it with a neprilysin inhibitor. Back to our topic on cardiac heart failure, there are certain drugs which can be which can be used to decrease the heart rate, and one such drug is Ivabradin. So this is an interesting name, Ivabradin. And we can also use drugs which increase the intrinsic contractility of the heart, and you probably already understand that the contractility of the heart is directly proportional to the amount of calcium in the cardiomyocytes. So if you understand that, this is going to be very easy. Certain drugs which do that include the cardiac glycosides like digoxin, digitoxin, ubiane, as well as other drugs like dopamine and dobutamine. Dopamine and dobutamine have different sites of action. They basically bind to beta receptors found on the heart muscle, and that's how they have their effect. There are also certain drugs, right? There are also certain other drugs, basically not just drugs, which have the same effect, although in a more roundabout manner, so to speak. And the names are milirinan and enamrinan. Right? They have the same effect in a different manner. Let me just write these down. Milirinan and enamrinan. They're basically having the same mechanism of action. Right? Let me just correct this. Right? So cardiac glycosides, they basically inhibit the sodium potassium ATPase pump, which is linked to the sodium calcium pump. When the sodium potassium pump is inhibited, there is less sodium getting pumped out, and so less sodium enters via the sodium calcium pump, and therefore less calcium is removed from the cardiac myocyte, and the calcium that remains in the cardiac myocyte accumulates in the SCR and further leads to release of calcium from the SCR by a mechanism known as calcium-induced calcium release. Right? When there is more calcium in the cytoplasm, it leads to more release from the calcium deposits in the SCR, and the higher the intracellular calcium level, the more force of contraction developed by the heart. In first physiology, in the musculoskeletal topics, we talked about myosin and actin interaction, which leads to the development of force of contraction. The more the interaction, the more force is generated, and the interaction is dependent on certain binding sites being available, and calcium is basically what makes those binding sites available. So this is basically a descriptor on the action of the cardiac glycosides and how basically they act by increasing the availability of the intracellular calcium. So we can say that these cardiac glycosides are positive inotropes. Again, a terminology we have already encountered in first year physiology. Digoxin can be given both orally as well as parenterally. The absorption orally is pretty good, 65 to 80%. The volume of distribution of digoxin is also good because it binds to various tissues found in the body, and this has certain pharmaceutical implications. Digoxin does in fact cross the blood-brain barrier, which is a tidbit that should be remembered. It doesn't have much in the way of hepatic metabolism, and the excretion of digoxin and digitoxin is mainly in the unchanged form via the kidney. So in a person with renal insufficiency, there should be dosage adjustment of the digoxin. Another important thing. Now the half-life of digoxin is relatively long, which needs to be considered when we consider Digoxin toxicity. When we're considering the toxicity of digoxin or digitoxin, two things need to be considered. The renal status of the individual being the first thing that you consider, and the co-administration of certain drugs which can potentially replace the binding site of digoxin. So certain important things. Right. So digoxin has two effects. It increases the contractility and it reduces the heart rate. How does it increase the contractility? We've already sort of encountered that. What about the effect on the heart rate? So we're saying that the SA node as well as the AV node are sort of inhibited, and this can be termed as a parasympathomimetic or an indirect effect of the administration of digoxin. What do we observe? We observe a fall in the heart rate. Why? In first year physiology, we basically talked about the action potentials in the heart. There were two types. The action potentials developed by the ventricular musculature, and those action potentials developed by the conductive tissues of the heart, say the SA node and the AV node. So when you give digoxin, there is an effect, there is an accumulation of intracellular calcium, but there is also an effect on the sodium potassium pump in both the SA node and the AV node. There is a phase in the action potential known as the slow depolarization phase. This particular depolarization phase is when very gradually the membrane potential is increasing in the positive direction. But because of the effect on the sodium potassium pump, this becomes a very non-steep process. This takes a long time, and so the heart rate falls. This is the reason why you do give digoxin and digitoxin and the cardiac glycosides in patients who are suffering from arrhythmias, like for example atrial fibrillation or atrial flutter or something like that, right? So very important things. As far as the toxicity is concerned, if a patient is on digoxin or something and they suddenly complain of nausea and vomiting and diarrhea, don't take that easily. Don't say that these are just normal side effects which we encounter with a lot of drugs, because when these are encountered with digoxin, that is a bad sign. The reason for that is that digoxin has a very narrow therapeutic index, so it's very easy to kind of like cross into the toxic range. So if a person starts showing these symptoms, very soon the person might develop toxicity, and the most toxic, the most common serious life-threatening toxic consequence is the development of, interestingly, arrhythmias. Before that, a person might complain of blurry vision with yellowish green vision with a halo-like appearance. So if, for example, a person develops digoxin toxicity because you were not careful enough, or maybe because the situation was that hard, there were a lot of things you needed to consider, the renal insufficiency among others, as well as poor administration of drugs like quinidine. So what you do is that you either supplement with potassium, which inhibits the effect of the drug, or you give something like an immunoglobulin which is specific to digoxin. This is known as the Fab immunoglobulin or the digoxin immunoglobulin Fab, which binds to and neutralizes the effect of digoxin. So this is a very quick remedy when you don't have time to do something else. Because of the arrhythmic effects of the digoxin, when the digoxin levels are in the toxic range, what you do is that you give either lidocaine, which is an antiarrhythmic, in order to counteract those potential toxic effects, and if the situation is very bad, you might use a cardiac pacemaker to prevent the toxic arrhythmic effects of digoxin toxicity. There are certain things which increase the toxicity of digoxin. For example, if a person has developed hypokalemia or hypomagnesemia because of certain drugs. For example, if you're giving digoxin along with a diuretic, it can lead to hypokalemia because most diuretics are potassium wasting. Or if you were giving a loop diuretic, that can often lead to hypomagnesemia. So because of these concurrent electrolyte imbalances, digoxin toxicity is increased. Hypercalcemia also increases the toxicity of digoxin. So we are basically done with cardiac glycosides. What about dopamine and dobutamine? Both of these will act on beta receptors on the heart, and this will lead to the activation of a GS, which is a G protein stimulatory, which will lead to the activation of a adenylyl cyclase molecule. Please go back to your biochemistry in first and second year. This is known as a signal transduction pathway, and this is one of the more common ones. And adenylyl cyclase will lead to the formation of cyclic AMP. This cyclic AMP will activate a protein kinase, which will go and phosphorylate a calcium channel. And this phosphorylated calcium channel will allow the extensive influx of calcium, and this is basically what will lead to the contractility. So this is a mechanism of action of dopamine and dobutamine. The thing to know about dopamine is that different doses of dopamine have different effects. For example, if you were to go with a low dose administration of dopamine, there won't be much effect on the heart, but the renal perfusion will improve. If you give intermediate dosing, that will increase the contractility of the heart. And so intermediate dosage of dopamine is what we are interested in when discussing the pharmacology of cardiac heart failure. If we give high dose of dopamine, that is a good treatment for cardiogenic shock secondary to cardiac failure. Right, so what about milrinone and inamrinone? And I've probably written these spellings a bit, I'm pretty sure these are wrong spellings, so please check these out. So normally the cyclic AMP that is being produced as a part of the signal transduction pathway activated by the interaction of beta and agonist with the beta receptors. So normally the cyclic AMP is produced because of the interaction of dopamine or dobutamine with those beta receptors. And then the cyclic AMP does its job of activating the kinase, which phosphorylates the channels, and after it has done its job and after the stimulation is over, the cyclic AMP is degraded as a part of normal homeostasis. But if you were to give milrinone or inamrinone simultaneously, these are known as phosphodiesterase 3 inhibitors. Now the phosphodiesterase 3 inhibitor, if you remember from your biochemistry, is that enzyme normally found which degrades the cyclic AMP after it has done its job. So this leads to the accumulation of phosphodiesterase 3, and basically this leads to more cyclic AMP getting accumulated, and this increases the contractility of the heart in patients of cardiac heart failure. So this is an important thing that needs to be recalled. One important thing that I almost forgot to tell you is that when we talk about the cardiac glycosides like digoxin, and we talk about the parasympathomimetic effect, which leads to the fall in heart rate and which makes this a very ideal drug in the treatment of arrhythmia, is the fact that when we're trying to explain the effect on heart rate, we use the term increased refractory period of the AV node. So this is something that can come up in an exam. So these are basically increasing the contractility, but each of these has different mechanisms of action. This one basically has an effect on the sodium potassium pump, this has an effect on the beta receptors, and this has an effect on PDE3 inhibitor. Ivabradin is something that decreases the heart rate. So I'm hoping this was an interesting and helpful video.